tachycardia, pulse pressure, rash, mucosal bleeding, hepatomegaly, clinical evidence of pleural effusion. Ascites, it may be difficult. Tourniquet test can be done. Capillary refill time can be done. Complete blood count can be done. And diagnose, you're categorizing it as mild, moderate, and severe. So actually, after this class, when you're sending a referral, you should be able to write it as possible, probable dengue fever, moderate B1, B2, or probable dengue fever, severe C1, C2, C3. So it indicates that we have categorized our patient properly. So approach, mild dengue can be managed on OPD basis. Moderate dengue, we need observation or admission for in-hospital management. Severe dengue definitely needs urgent referral. So these are the things when you are triaging any case, any fever case, triaging. The parameters, duration of fever, presence of warning signs, high-risk groups, tourniquet test, vital signs, and peripheral perfusion by pulse volume. Mild dengue, symptomatic and supportive, rest, fluids, oral fluids are enough. IV, there's no need of giving. Fever, you give paracetamol 4 to 6 times can be given. Cold, tepid sponging. We have to monitor the patient clinically for 24 to 48 hours after becoming afebrile without the use of antibiotics. And always look for warning signs, platelets, and hematocrit value. When we should do CBC, all patients with warning signs, whatever be the duration, if it is in the second day of fever itself, we have to do CBC and blood RBS. Patients with fever more than 3 days without any warning signs, we have to do. Educate about the warning signs and report if they appear. This is again, I'm keep on repeating this so that you remember we have to tell these to the patients. I know there'll be a lot of cases in your OP. Either that or you make somebody else say, or you give classes, or you can give a session outside the OP when people are waiting. You can ask a JPHN or somebody to take a class and educate them regarding these warning signs. During fever season, so that any such warning signs they can come and report at the earliest. Same, severe abdominal pain, bleeding, vomiting, melena, drowsiness, pale, cold or clammy skin, difficulty in breathing. Then again, follow-up importance is whether your mild case is becoming moderate or whether your moderate case is going to severity. That is very important. Then here, this is the national guidelines by NVBDCP. So what they say is serial hematocrit at least every 4 to 6 hours in stable cases. But usually at DH and all, what we do is every 24 hours we are going to do. If there is a rapid fall in platelet, we do it once in the evening also. And hematocrit levels usually should be done before fluid resuscitation. Urine output should be recorded every 8 to 12 hours. If the patient is in shock, hourly we have to do. In case of severe critical period is the period of plasma leakage. It starts from febrile to afebrile phase. There is rapid fall of thrombocyte, platelet count. That is important. So if you're seeing a patient with a platelet count of 1,30,000, after 2 days you're repeating, it has become 1 lakh. See, what is happening is now we are seeing referral for a fall in platelet from 1,30,000 to 1 lakh or 1,05,000. Patient being referred as with fall in platelet and thrombocytopenia. So what is going to happen is when this patient reaches a tertiary level center, definitely we can't send the patient back, because if you say this platelet is okay and send them back, what is going to happen? Platelet fall is going to happen for another 24 to 48 hours. They go and check again, there'll be further fall. So referral for just a gradual fall in platelet is not needed, because once you refer a patient, we can't send them back and we admit this patient in our bed. So what is going to happen? Another 2 days, it is going to fall. So this patient stays admitted for another 3 days. As a result of which, that bed is blocked. And the severe cases, when they come, we'll have to refer. So while referring, see to it that it's the rapid fall in platelet count or a fall in platelet with bleeding manifestations you refer. Otherwise, you can always look for it. You can tell the patient, see, with the ഇപ്പൊ പനി കുറഞ്ഞു കഴിഞ്ഞാലാണ് ഈ കൗണ്ട് കുറയുക. ഇത് കുറയാൻ തുടങ്ങിയ ഒരു 2-3 ദിവസം കുറയും, പിന്നെ അത് കൂടാൻ തുടങ്ങും. അപ്പൊ അത് കാരണം നമ്മൾ എല്ലാ ദിവസവും ഇത് ടെസ്റ്റ് ചെയ്യണം. യു ജസ്റ്റ് ടെൽ ദം, ദേ വിൽ ബി ഓക്കെ വിത്ത് ഇറ്റ്. And then you check, so next day it is falling, they'll be like, okay, what this doctor has told, it's correct. And they'll be happy that it is falling. Okay. So there is a rapid fall or a fall with the bleeding manifestation, definitely you can refer. Otherwise, you can just manage on a daily basis, you can check, ask them to come. That is enough. And look for warning signs. IV fluid therapy should be started in patients with poor oral intake or further increase in hematocrit or those with warning signs, you have to start IV fluid. Then always while monitoring general condition, vital signs, it's very important. Criteria for admission. This is another thing. So who are the patients which you're going to admit? One is significant bleeding from any site, signs of hypotension, persistent high-grade fever, a rapid fall of platelet count, evidence of organ involvement, dengue patients with warning signs and symptoms. So these are the patients who need admission. These are the ones who should be referred. Now, these are the fluid management. Actually, I'll be sharing these slides. And again, even though in guidelines, these things are there, fluid management should be individualized. Now, if a patient with myocarditis, a patient with chronic kidney disease, or a patient with acute coronary syndrome, or a severe LV dysfunction, definitely you can't give these fluid as written in these guidelines. So it has to be individualized and you have to monitor the vitals, you have to monitor the urine output, and accordingly you can give the fluids. So for moderate degree, you usually start with 7 to 10 ml per kg per hour for 1 hour. And then based on the improvement, you can step down. So the fluid, ideally what you have to use is, you can use normal saline or ringer lactate. Please don't use 5% dextrose. Then again, all patients' blood sugars should be monitored because dengue with diabetes, again, if it is an uncontrolled diabetes, the mortality is very high. Patient can develop diabetic ketoacidosis also. Again, urine output, these are the things which you have to monitor. And fluid should be stopped after 24 to 48 hours because another cause of mortality in dengue is because of over fluid management, which later on leads to pulmonary edema. The things you have to monitor, again, these are the same things: temperature, pulse, respiratory rate, blood pressure, urine output, hematocrit. In severe dengue with compensated shock, usually you give 10 to 20 ml per kg per hour for 1 hour. Then based on improvement, you're going to step down. Only thing you have to remember is, so 10 to 20 ml, again, you can give 1.10 NS if it's a 60 kg individual, up to 1200. So definitely by the time you refer over 1 hour, if it's taking, you can at least give 2 of NS for the patient. In case of patient coming with shock, 20 ml per kg, over 15 to 30 minutes you can give. So you have to just push the fluid. You have to push 2 pint over 30 minutes. That has to be done in patient coming with shock. Again, this is the same thing what is there in the chart. Again, while investigation, admitted patient's blood group has to be investigated because at times if there is severe bleeding, blood transfusion should be given. Now, when we are going to stop the fluid, it should be reduced or discontinued when there is normal blood pressure, decrease in hematocrit, fever has stopped without antibiotics for more than 24 to 48 hours, resolving bowel or abdominal symptoms, improving urine output. Patient is able to take orally, there are no danger signs, there is no vomiting. Definitely, you can go for oral therapy. So you have to admit the patient severe cases, investigate, look for cause in case of bleeding, admit the patient, look for the cause and site of bleeding, make immediate attempt to stop the bleeding. GI bleeding, severe epistaxis and hemoptysis may present with profound shock. Urgent blood transfusion is needed. If blood is not available, shock may be managed with proper IV fluid. You can give push ringer lactate. Then there is thrombocytopenia, active bleeding, platelet transfusion can be done. In case of massive hemorrhage, you have to look for coagulopathy. You have to test for prothrombin and APTT. If there is coagulopathy, you have to give fresh frozen plasma also. Now, what are the indications for platelet transfusion? This is another thing we all should be knowing because with the increase in number of cases, what is going to happen is there is a run everywhere for platelet. So there is no need to give prophylactic platelets even if it is less than 20,000. Now, what they say is prophylactic platelet transfusion may be given at the level of less than 10,000 in the absence of bleeding manifestation. However, platelet transfusion may also be given if there is prolonged shock. And in case of systemic massive bleeding, you have to give platelet transfusion in addition to PRBC transfusion. Standard dose for adults is 5 to 6 units of random donor platelet or 1 unit of apheresis platelet, which is not available for us. So that is even if you give one, it increases by 5,000. And again, when you give platelet, actually platelet is something which is always kept in an agitator. So when you're bringing the platelet also, it should be transfused fast, and while bringing also, it has to be continuously agitated. Now, this is another thing, criteria for discharge of the patients. Hospitalized patient should be discharged if the patient has recovered from acute dengue infection. That is, there is no fever for last 24 hours, normal blood pressure, adequate urine output, no respiratory distress, and persistent platelet count of more than 50,000. So one day you've seen it is 50,000, second day it is 60,000. Then also, if the patient has been afebrile, we can always discharge. But another important point I want to stress here is when you're checking the platelet count for monitoring, it is also important that you always check the hematocrit. Because if the hematocrit is rising, even the platelet count is rising, hematocrit is also rising. It's always better that you keep the patient and you discharge them only once the hematocrit value starts coming down. Because increasing hematocrit usually tells that the capillary leak is going on. So these are the criteria for admission, and these are the criteria for discharge, which I've already told.
Don't take too much of it. If you push too much of it, there is chances of embolus again.
But question ആയിരുന്നോ ഇതിന്റെ ഇടക്ക്?
Questions നമുക്ക് അവസാനം എടുക്കാൻ തോന്നും മാഡം. അല്ലെങ്കിൽ chat box ഇട്ടാൽ മതി എന്ന് പറയും.
Okay. Abang, these are the criteria for admission. This is the criteria for discharge. Prognosis, like I said, mortality is usually less than 0.1%. Early recognition of shock is very important. Shock identify early when the pulse pressure is narrowing. IV fluid, if administered at this stage, has got an excellent outcome. Poor prognosis when there is prolonged shock, because prolonged shock leads to multiple organ failure, leads to renal failure, it leads to ischemic hepatitis. So once there is multiple organ failure, the prognosis is very bad. Adverse outcomes, even without shock, you see in encephalitis, disseminate intravascular coagulation, myocarditis, fulminant hepatitis, and ARDS. So even without shock, if the person with dengue gets these things, their mortality is very high. So that was with respect to dengue. I'll continue. Continue cheyalla. Okay, this is leptospirosis also. I think these are the things which we start with every infective disease.